Hello and welcome. My name is Jeff Taylor and we're here at the 2019 CROI in Seattle, Washington. And I'm here today with two researchers, Dr. Peter Hunt from UCSF and Dr. Sara Gianella from UC San Diego. So welcome. Thanks for joining us today.
Thank you.
Yeah, thanks for having us.
So I guess we're here today to talk about inflammation. So we hear a lot about inflammation in HIV, but what do we really mean about that and why is it so important?
Yeah, so inflammation is really the process that your body does in response to an infection or some sort of damage. You hit your thumb with a hammer and it becomes swollen, inflamed, red, painful. That process is inflammation. But a lot of diseases like HIV, even when your viral load is undetectable on therapy, there's low levels of inflammation in the body, a little bit of overactivity of the immune system that takes its toll on all the organs in the body. So it can contribute to heart disease, a risk of cancer, risk of bone disease, osteoporosis.
So all the things we worry about in HIV these days.
Yeah, so a lot of the things that we know now are increased in people living with HIV, particularly as they get older, we think have been linked to the inflammatory process. And so a lot of us have been working on trying to figure out why inflammation persists despite treatment of HIV. And we've come to realize that there are a few root drivers of this inflammation. One is HIV itself. It stays there in the body. If you stop therapy, the virus will come right back. And so we know that we don't fully get rid of HIV with the treatment. We just suppress it. But that little bit of HIV coming out of cells may cause problems. We know that the gut barrier. So you have in the lining of your gut that keeps all the poop and the bacteria in your stool from getting inside the body, causing problems. You have a brick wall there, and that brick wall gets leaky during HIV infection. While it gets repaired a little bit with treatment of HIV, it doesn't fully repair itself, and so little bits and pieces of bacteria can still get into the body and cause inflammation too. But there's also a third big contributor. It's another virus that most people living with HIV, over 90% have, called CMV, that we think may be playing a really important role in contributing to a lot of the inflammation that we see.
So, Dr. Gianella, can you tell us more about CMV and then why it's so important in the setting of HIV?
Yes, I'm very happy to, because as everybody knows, CMV is one of my great passions. So, as Peter said, CMV is a virus. CMV has some similarity with HIV because once somebody gets infected with CMV, you will really never get rid of it. So, you have a chronic viral infections. Most people get infected with CMV at a very young age, like either when they are children or at the latest in the teenager years. And as Peter said, over 90% of people, especially people living with HIV, are also co-infected with CMV. And CMV usually causes problem like florid disease in people that are very sick and with very low CD4 T cells.
Yeah, I remember in the early days of HIV, many people were going blind and having other complications.
Exactly, and we don't see that so much anymore. Right. But what we have realized, like my group and Peter's group and many others that have been studying CMV related to inflammation, is that even when the immune system is actually intact, CMV can still replicate at very low level in various mucosal sites like the mouth or the genital tract and salivary glands. And we think that it can contribute significantly to this ongoing inflammation. We know people living with HIV have more CMV replication, even if they never notice it. We know that if we sample semen and saliva from people living with HIV, 80% of them have some CMV somewhere. And there are a lot of publications that associate CMV with inflammation. But what we don't know right now is the direction, right? Is CMV like a root cause of inflammation, or just people that have more inflammation tend to have more CMV.
So what are we doing about this? If we think CMV might be a problem, what are we doing to find out if it is and perhaps address it?
So we did a study several years ago treating people living with HIV who didn't recover normal T cell counts despite treatment for their HIV infection, to see whether treating CMV that wasn't causing them any symptoms at all, that low-level CMV replication that Sarah is talking about, using a drug called valganciclovir, to see whether it might reduce immune activation. And way back then, this is almost a decade ago now, we showed that it did decrease some markers of immune activation. And we're now, but unfortunately that drug has a lot of side effects. So it can lower your blood count and make you feel really tired, and even some of the immune cells in the blood might be affected eventually, and that's the last thing we would want to do. And so it didn't make sense to move forward with that medicine as a treatment strategy to reduce inflammation in people who are otherwise healthy. But now we have new tools available new therapies that have been developed to treat CMV that seem to have far fewer side effects. And so we've gone back to that early study and found really remarkable things, that testing more inflammatory pathways that
using the samples from the old study.
Using the samples from that old study, and we're here at the CROI 2019 right now. We're presenting some of those data here at the meeting, but essentially that study was the strongest, most consistent treatment to reduce immune activation that anyone has studied in the last 10 years have treated HIV. A lot of these biomarkers of inflammation that strongly predict things like heart disease, like type 2 diabetes, like mortality, are going down by an entire quartile. A quartile is like 25% of all people go down. A major reduction, and the effect sizes we think that we saw might translate to like a 22% decreased risk of heart disease or a stroke. Might decrease, correlate with about a 50% reduction in type 2 diabetes risk. So really profound effect sizes, and so we're quite excited about this as a possible real therapeutic strategy now that we have new treatments available that may be safer to treat HIV.
So are you designing another trial then to explore this hypothesis?
So yes.
As a matter of fact.
Peter and I are co-chairing an upcoming trial through the AIDS clinical trial group. So it's ACTG 5383, if you're interested in the number, where we are treating people living with HIV with letermovir for 48 weeks. And it's a randomized, double-blinded, placebo-controlled trial of letermovir. And
what kind of patients are you looking for the trial?
Sorry,
you okay?
So we're trying to enroll people living with HIV that are suppressed on their current regimen, but we're particularly interested in finding people who have low CD4 counts despite several years of treatment, because we think some people say immunologic non-responders. Your CD4 count just doesn't come back to normal despite suppressing the virus, and we think CMV is likely playing an even greater role in people like that. We also want people who have recovered normal CD4 counts too, but it's particularly important that we get people who have low CD4 counts as well.
And that's really gratifying to hear, because I mean that's been, for long-term survivors especially, there are a number of people who, no matter what they do, they've done everything right, they're taking their meds, cannot get their T cell count back up, and they have to stay under their meds to keep from getting sick. It's a real problem.
Another important category that we really want to enroll is women. And I know historically we have not done very well enrolling women in many studies, but this particular study, I think it's important, and we are actually aiming for at least 25% of our study participants to be women, because we know that women have a different immune system and that women react differently to viral infections. And so it will be very important, in particular for women, to know if CMV is a major contributor for inflammation. And I think so we need women for this study.
Yeah, that's always been a problem in HIV research, especially. People think of it still as a gay man's disease, and it certainly isn't. Worldwide, half or maybe a little more than half of all people living with HIV are women. Do you have special strategies on how you're going to get more women into this trial?
Well, one of the strategies is to set a minimum 25%. This means that if we enroll too many men, eventually we will stop enrolling men and offer the trial only to women.
Good.
And we will talk with the community for sure, and with the ACTG community partners to try to really enhance our outreach to the women population.
That's terrific.
I'm sorry.
Oh, no worries. It's winter in Seattle.
Can we edit out my coffee?
It's real life.
Yeah.
So is there anything else you want to tell us about the trial? Or?
Well, there's a bunch of sub-studies in the trial that we think are really important. So the goal is not just to reduce some lab test, some biomarker in a blood sample. While we think that's important to show that we're having an effect of the intervention, we want to show that we're actually decreasing the risk of heart disease, decreasing the risk of diabetes. And in order to do that, we need to build in these sub-studies that look for effects on the blood vessels. Like, can we reduce inflammation in the lining of the aorta? And we can do that with fancy imaging techniques now called FDG PET. It's just a fancy scan to measure the amount of inflammation. So we want to see if the treatment reduces that. We have a feeling that treating CMV is going to have a major effect in the blood vessels and heart disease risk, because when the immune system is really weak, say if you get a solid organ transplant and go on potent immunosuppressive drugs, we really see increased risk of heart disease when that happens. And we know that treating CMV and preventing CMV from replicating actually decreases heart disease risk in that setting.
Oh, wow.
So we think that a similar thing may be happening in HIV, although in a smaller scale.
Right.
And so that imaging will help give us a clue as to whether we're making some progress there. Another thing that we're encouraging participants to consider is a fat biopsy study. So just a little bit of fat in the belly.
Most people I'd be happy
to donate some of mine. It's been growing over the past couple months. But it turns out that CMV actually also replicates in the fat tissue. And one of the things that several of our colleagues have seen in looking at fat tissue in people with HIV is they see a lot of immune cells that go into the fat responding to inflammation there. And as a consequence of the inflammation in the fat, you get scarring of the fat tissue. And when you get scarring of the fat tissue, that fat, the normal fat cells that normally expand when you eat too much, as my fat has done, it can't go into the fat cell anymore, and it has to go to other organs in the body. And so fat gets deposited in the liver. So you've heard about NASH, or non-alcoholic steatohepatitis, or fatty liver disease. That's a major problem in people living with HIV, and it may contribute to diabetes risk and further contribute to heart disease risk. And so we think looking at what's happening in the fat tissue may give us clues as to whether we're on the right track in preventing some of those complications as well in people with HIV.
Well, I know early on when we first got effective treatment, we started seeing lipodystrophy, right? Fat redistribution in very strange ways. Either they're losing all the fat in their extremities or in their faces, or gaining it, in their belly, or even on their, getting buffalo humps and things like that. So it's fascinating to see that story kind of coming around. And
it's a new dimension of that now. Yeah.
We also have a neurosub study where so cytomegalovirus has been associated to neurocognitive impairment, but also to depression and inflammation in the cerebrospinal fluid, which is the fluid who is around our brain.
Right.
And so our third sub-study will be to collect a little bit of this fluid and measure level of inflammation, and also to run some neurocognitive batteries and emotional batteries to see if treating CMV also has a positive effect on depression and neurocognitive impairment.
So that would be a spinal tap then that they would do?
Yeah.
Fascinating.
Yeah. So I think there is so much to be gained, knowledge to be gained with this study. Peter and I have been planning this study for years, and super excited that finally we are getting there. And we encourage people to participate and also to consider all three sub-studies, because we really believe that CMV is one of the root cause of inflammation and some of the disease that we see in people living with HIV.
No, this sounds fascinating. It could answer a lot of questions we've been wanting to know about for a long, long time. How can people find out more about the study?
You can contact your local ACTG site to see if they're participating in the study and to enroll. You can go to the ACTG website as well to get more information about the study. You can also email Sarah and I, and we're happy to respond.
And we are not starting enrollment yet, but we hope that maybe late summer.
So sometime later this year,
in
2019. Yeah. Terrific.
So I also have another study that I would like
one
to
more.
talk about. So in parallel with the letermovir study, we are also developing a CMV vaccine trial. So I think that as I'm excited about both, I think the letermovir trial is a more direct way to suppress cytomegalovirus. But as you can imagine, if it works, it's not really scalable to the entire population, because I don't think that we can ask every possible person living with HIV to take letermovir for the rest of their life. And so one of our collaborators at the City of Hope, they developed a vaccine. It's called Triplex. It has had very positive results in a phase 1 trial with healthy volunteer, and they also had, very recently, they presented some data on stem cell transplant patients. They administered the vaccine on over 100 people who are very sick, right, after a stem cell transplant. And so it's very safe, it's very effective, and it significantly reduced CMV viremia in these patients.
So this is a therapeutic vaccine. It doesn't prevent people from getting CMV. It treats their CMV.
Well, that's a good question. Like in the setting of stem cell transplant, it's different. But we will be using here as a therapeutic to try to control, because all people will already be infected, and we are just trying to boost the immune system in a way that it will do a better job in controlling this low-level replication that bothers us so much. So basically, we have kind of two trials in parallel, letermovir and the 5355, which is the CMV vaccine trial. I think I am excited about both of them. I think both are providing us with complementary information, and so I really encourage people to consider either one of them. You cannot really be enrolled in both, not in both together.
Right.
And similarly for the vaccine trial, we are really looking for women to enroll, because again, we have data that women respond to vaccine in a different way than men. So we encourage women in particular to reach out. It is a safe vaccine. It has been tested in people who are much sicker than people living with HIV without any major adverse event. We are following people for up to 96 weeks after vaccine to be 100% sure that there are no side effects. And so similarly to the letermovir trial, it's coming out soon. It's not ready to enroll yet, but we hope that the CMV vaccine will be ready earlier in the summer because we are a little bit more advanced and we don't have all this sub-study. We make it a little bit harder to develop.
So you won't have the same sub-studies in that one?
No, we don't have sub-study in that one.
Now, are you also looking for the immunologic non-responders for the CMV
no,
vaccine?
for the CMV vaccine, no, because of course to respond to the vaccine,
Right.
we need people who have a decent immune system. So if I'm not wrong, I think the lowest we can go is 250 CD4 T cell and 100 nadir CD4 T cells.
Oh, really? So the nadir, because many people,
I
long-term
know.
survivors, had much lower.
I know. That's our way to maximize the response to the vaccine, especially because this is a very early trial, and we will expand. So if this works, we will for sure expand it. But right now, because it's a vaccine and it requires an intact immune system to respond, we wanted to kind of maximize our chance to see something.
Yeah, that makes sense. Well, this is very exciting. Thank you so much for stopping by and sharing this with us.
Thank
Sure.
you. Thank you.
Best of luck in the study, and if people want more information, just go to the ACDG website. You can learn more.
Sure.
Thank you.
Great.
Thank you.
Thanks.